Morning class. So today we're going to be going over chapter 28, head and spine injuries. So trauma applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. Head, facial, neck, and spine trauma, recognition and management of life threats, spinal trauma. Pathophysiology, assessment and management of spine trauma, skull fractures. Nervous system trauma, pathophysiology, assessment and management of traumatic brain injury, spinal cord injury. So, introduction. The nervous system is a complex network of nerve cells that enables all parts of the body to function. That includes the brain, spinal cord, and several billion nerve fibers. The nervous system is well protected. The brain is protected by the skull. The spinal cord is protected by the spinal canal. Despite this protection, serious injuries can damage the nervous system. Anatomy and physiology. The nervous system is divided into two anatomic parts, the central nervous system and the peripheral nervous system. So here's a diagram with the central nervous system. Okay, so connecting nerve cell, sending down impulses to your brain and to your spinal cord. They interact with one another. Okay, so your central nervous system includes the brain and spinal cord. The brain controls the body and is the center of consciousness. Brain is divided into three major areas: the cerebrum, cerebellum, and the brainstem. Okay, and then another diagram of the brain. You have your spinal cord down here, your cerebellum, brainstem. It's going to be right over here. Okay, your cerebrum. It's probably going to be the biggest part of your brain. Okay, and then your different types of lobes. You guys should know where your lobes are and how to say which part of the head. And in terms of the medical term, you have your frontal lobe, your temporal lobes, and then parietal and occipital back here. So if you have an injury on the back of your head, you're going to say it's an injury to the occipital area. Or if a patient has a laceration back there, you could say occipital region. Cerebrum controls a wide variety of activities, including most voluntary motor function and conscious thought. Contains about 75% of the brain's total volume. Divided into two hemispheres with 4 lobes. Cerebellum coordinates balance and body movements. Brainstem controls most functions necessary for life. Best protected part of the central nervous system, or CNS. You guys should know the different parts of the brain and what they do. Your spinal cord, made up of nerve fibers that extend from the brain's nerve cells, carries messages between the brain and the body via the gray and white matter of the spinal cord. Protective coverings. The entire CNS is contained within a protective framework. The thick, bony structures of the skull and spinal canal withstand injury very well. CNS is further protected by the meninges. Meninges are our outer layer. Dura mater is a tough, fibrous layer that forms a sac to contain the CNS. The inner two layers, arachnoid matter and pia mater, contains the blood vessels. So an easy way to remember is your different layers. So meninges is from the innermost to the outermost region is going to be PAD. PAD is your acronym. So you're going to go pia mater, arachnoid matter, and then dura mater, as in PAD. And this, you guys should also know, when older people have falls or people hit their head and they have a bleed, usually it's a subdural bleed. So it's below the dura mater. And then if you hear any arachnoid bleeding, it's going to be in the arachnoid layer. So here's another diagram. So you have your dura mater right here, and then you have your arachnoid region right here, and then your pia mater right here. Okay, so like I said, when older people fall, they're usually going to have a subdural bleed once they do a brain scan, so the bleeding is going to be below the dura mater because it's a subdural bleed. An epidural bleed is going to be above the dura mater. So a bleed in between here. Okay. So cerebral spinal fluid, or CSF, produced in a chamber inside the brain called the third ventricle. Approximately 125 to 150 milliliters of CSF in the brain at any time. Primarily acts as a shock absorber. So if you hit your head, it's going to help absorb a little bit of it so you don't injure your brain. So peripheral nervous system, 31 pairs of spinal nerves conduct impulses from the skin and other organs to the spinal cord, conduct motor impulses from the spinal cord to the muscles. The spinal nerves serving the extremities are arranged in complex networks. Okay. So cerebrum, the brainstem, foramen magnum, and then your spinal cord all the way down. So you guys should know also your different types of areas or sections of the spinal cord. So you got your cervical, you got your thorax, lumbar, sacrum. So 12 pairs of cranial nerves transmit information directly to or from the brain, perform special functions in the head and face, including sight, smell, taste, hearing, and facial expressions. 2 types of peripheral nerves. Sensory nerves carry only one type of information from the body to the brain via the spinal cord. Motor nerves, one for each muscle, carry information from the CNS to the muscles. Connecting nerves, found only in the brain and spinal cord. Connect the sensory and motor nerves with short fibers. Allow the exchange of simple messages. How the nervous system works. Controls virtually all the body's activities, including reflex activities, voluntary activities, and involuntary activities. So connecting nerves in the spinal cord form a reflex arc. If a sensory nerve in the arc detects an irritating stimulus, it bypasses the brain and sends a message directly to a motor nerve. Okay, so see how this young gentleman is holding his hand over a flame. So it takes some time for the patient to feel heat on the hand, and it's going to send a nerve impulse back to the brain, telling him that it's warm, and he's going to have to take his hand away because it hurts. So that's how your sensory and your motor nerves work. Voluntary activities are activities we consciously perform, and voluntary activities are the actions that are not under conscious control. Somatic or voluntary nervous system handles voluntary activities. Autonomic, involuntary nervous system handles body functions, divided into 2 sections, your sympathetic and your parasympathetic nervous systems. Your sympathetic nervous system reacts to stress with a fight or flight response. Parasympathetic nervous system has the opposite effect on the body. So your skull, it's composed of 2 groups of bones, and the cranium, the thick shell above the eyes and ears that protect the bone and facial bones. So I'm sure you guys have seen this diagram a few times. Your cranium, your nasal bone, your zygoma is going to be your cheekbone. Maxilla is the bone right above your upper lip, and then your mandible is going to be your jaw. And your temporomandibular joint, which your jaw pivots on, is going to be right here. Cranium is composed of 80% brain tissue, 10% blood supply, and 10% CSF. Remember that 10% CSF acts as a shock absorber for the brain. 4 major bones make up the cranium: occiput, temples, parietal region, and frontal region. Face is composed of 14 bones: maxilla, zygomas, mandible, and orbit. Spinal column is the body's central supporting structure. 33 vertebrae are divided into 5 sections: there's cervical, thoracic, lumbar, sacral, and coccygeal region. Like I said, you guys should know all the different types of sections that the spinal cord is separated into. So cervical, it's going to be very up top. Thoracic is 12, lumbar 5, your lower back. your sacrum, and your coccyx. Okay, so an easy way to remember the top three is when you breakfast at 7, so 7 cervical vertebrae, lunch at 12, so you got 12 thoracic vertebrae, and dinner at 5, so lumbar, you have 5, so 7, 12, and 5. So breakfast at 7, lunch at 12, dinner at 5. Easy way to remember that. So spinal column. Injury to the vertebrae can result in paralysis. Vertebrae are connected by ligaments and separated by cushions called intervertebral disc. Spinal column is almost entirely surrounded by muscles. Traumatic insult to the head that may result in injury to soft tissue, bony structures, or the brain. 52,000 deaths occur annually in the United States as a result of severe head injury, account for more than half of all traumatic deaths. So closed injuries. The brain has been injured, but there is no opening into the brain. So if you have any type of injury where the skin is not broken, it's going to be considered a closed injury. The open injury is an opening from the brain to the outside world, or if you have an open wound anywhere else on the body, it's going to be an open injury, often caused by penetrating trauma, maybe bleeding and exposed brain tissue. Motor vehicle crashes are the most common MOI. Head injuries also commonly occur in victims of assault. When elder people fall during sports-related incidents and a variety of incidents involving children, any head injury is potentially serious. Okay, so general signs and symptoms of a head injury you guys should be looking for. Following a head injury, any patient who exhibits one or more of these signs or symptoms has potentially sustained a very serious underlying brain injury. So lacerations, soft area or skull depression, visible fractures, decreased mentation, irregular breathing pattern. You guys should know your different types of breathing patterns. Widening pulse pressure, slow heart rate, ecchymosis about the eyes or behind the ear over the mastoid process. So this is part of your guys' physical. When you guys are doing a trauma, this is what you guys are looking for. So you have raccoon eyes. That's what they're called. Or battle sign. And they're also looking for a clear pink CSF leakage from a scalpel in the nose or the ear as well. That's why you guys are always checking. Failure of pupils to react to light. That could be another serious injury. Unequal pupil size, and you got all these other ones right here. So scalp lacerations can be minor or serious. Even small lacerations can lead to significant blood loss, may be severe enough to cause hypovolemic shock. They are often an indicator of deeper, more serious injuries. So significant force applied to the head may cause a skull fracture, may be open or closed, depending on whether there is an overlying laceration of the skull. Injuries from bullets or other penetrating weapons often result in skull fractures. Signs of skull fracture include patient's head appears to be deformed, visible cracks in the skull, ecchymosis, bruising that develops under the eyes. We talked about this, raccoon eyes. Ecchymosis that develops behind one ear over the mastoid process is battle sign. So remember, these are signs that you guys are going to be looking for when you guys are doing your full trauma assessment. This is why you guys do your full trauma assessment. You're looking at every possible injury that they might have. What's your index of suspicion? What do you think may have happened to the patient? Okay, so here you go. So you got raccoon eyes right here, and then you got battle sign back here. So also you might be looking for some CSF fluid or some clear liquid coming down out of the ears right down here. So linear skull fractures account for about 80% of all skull fractures. Radiographs are required to diagnose a linear skull fracture because there are no physical signs. Depressed skull fractures result from high energy direct trauma to the head with a blunt object. Frontal and parietal bones are most susceptible. Bony fragments may be driven into the brain. Basilar skull fractures associated with high energy trauma. They usually occur following diffuse impact to the head. Signs include CSF damage, drainage from the ears, raccoon eyes, and battle sign. So here we have a little bit of blood coming out from a basilar skull fracture right here. It's coming up here as well, and some CSF. Okay, so open skull fractures result when severe forces are applied to the head, often associated with trauma to multiple body systems. Brain tissue may be exposed to the environment. Traumatic brain injuries, most serious of all head injuries, two broad categories: primary, direct injury, and secondary or indirect injuries. Primary brain injury results instantaneously from impact to the head. Secondary brain injury increases the severity of the primary injury. Secondary injury may be caused by hypoxia, hypotension, cerebral edema, intracranial hemorrhage, increased intracranial pressure, and cerebral ischemia and infection. Brain can be injured directly by penetrating an object or indirectly as a result of external forces. A counter-coup injury can result from striking a windshield. Head hits the windshield, the brain comes to an abrupt stop by striking the inside of the skull. Head falls back against headrest. Brain slams into the rear of the skull. So basically the brain comes forward, hits the front of the head, and then goes back and then hits the back of the head. So that is a counter-coup injury. Intracranial pressure, accumulations of blood within the skull or swelling of the brain can rapidly lead to an increase in ICP or intracranial pressure. Increased ICP squeezes the brain against bony prominences within the cranium. Signs of increased intracranial pressure: Cheyne-Stokes respirations, ataxic respirations, decreased pulse rate, headache, nausea, vomiting, decreased alertness, bradycardia, sluggish or non-reactive pupils, decelerate posturing, and increased or widening blood pressure, and Cushing reflex. So remember, know your different types of respirations, know your Cheyne-Stokes and your ataxic respirations. Intracranial hemorrhage, bleeding inside the skull also increases ICP. Bleeding can occur between the skull and dura mater, beneath the dura mater but outside the brain. So that would be a subdural bleed within the tissue of the brain itself. So between the skull and the dura mater is going to be an epidural bleed. Most of the time you're going to get a subdural bleed, so below the dura mater. So epidural hematoma, accumulation of blood between the skull and the dura mater, nearly always the result of a blow to the head that produces a linear skull fracture. Okay, so you guys see this right here, the blue, that's going to be your dura mater, okay? And then your hematoma is going to be between your head and the dura mater. Okay, so it's going to be an epidural bleed. So intercerebral hematoma, bleeding within the brain itself, can occur following a penetrating injury to the head or because of rapid deceleration forces. So it's gonna, your hematoma down here is gonna be below the dura mater. So it's gonna be a subdural bleed, unless it's below the arachnoid or the pia mater. Subarachnoid hemorrhage. Bleeding occurs into the subarachnoid space where the CSF circulates, results in bloody CSF and signs of meningeal irritation. Common causes include trauma or rupture of an aneurysm. Concussion, a blow to the head or face may cause concussion of the brain. Closed injury with a temporary loss or alteration of part or all of the brain's abilities to function without demonstrable physical damage to the brain. About 90% of patients do not experience a loss of consciousness. Patient with a concussion may be confused or have amnesia. Usually concussion lasts only a short time. Ask about these symptoms: dizziness, weakness, visual changes, nausea and vomiting, ringing in the ears, slurred speech, inability to focus. Lack of coordination, delay of motor functions, inappropriate emotional responses, temporary headache, and disorientation. Contusion, far more serious than concussion, involves physical injury to brain tissue, may sustain long-lasting, even permanent damage. A patient may exhibit any or all the signs of brain injury. Other brain injuries can arise from medical conditions such as blood clots or hemorrhages. Signs and symptoms of non-traumatic injuries are often the same as those of traumatic brain injuries. There is no obvious history of MOI or any external evidence of trauma. Spine injuries. Compression injuries can result from a fall. Forces that compress the patient's vertebral body can cause herniation of discs. Motor vehicle crashes can overextend the spine. Rotation flexion injuries of the spine result from rapid acceleration forces. When the spine is pulled along its length, hyperextension, it can cause fractures. Any one of these unnatural motions, as well as an excessive lateral bending, can result in fractures or neurologic deficit. When bones of the spine are altered from traumatic forces, they can fracture or move out of place. So patient assessment. Always suspect a possible head or spinal injury with motor vehicle collisions, pedestrian motor vehicle collisions, falls, blunt trauma, penetrating trauma to the head, neck, back, or torso. So remember your index of suspicion. What injuries are you going to suspect for certain type of MOIs? Always suspect a possible head or spinal injury with rapid deceleration injuries, hangings, axial load injuries, and diving accidents. Scene safety. Evaluate every scene for hazards to your health and the health of your team or bystanders. Be prepared with appropriate standard precautions, including gloves, a mask, and eye protection. Call for ALS as soon as possible. Mechanism of injury and nature of illness. Look for indicators of the MOI. Consider how the MOI produced the injuries expected. Focus on identifying and managing life-threatening concerns. Threatens to circulation, airway, breathing, external hemorrhage. Reduction of on-scene time and recognition of critical patient increases the patient's chances for survival, or reduction in the amount of reversible damage. So remember, you have your on-scene time is you're going to be trying to get out of there in less than 10 minutes. And then you also have your golden hour from the time of injury to the time the patient gets to the hospital. You want to shorten that time to about 60 minutes if possible. But always try and get off scene in 10 minutes or less, unless you have extenuating circumstances. Spinal mobilization considerations. Assess the patient and the position found. Determine whether or not a cervical collar needs to be applied. Assess the scene to determine the risk of injury. Form a general impression based on the level of consciousness and chief complaint. The backboard often places the patient in an anatomically incorrect position for a long period of time. Circulation to areas of skin may become compromised. Some patients could experience respiratory compromise while laying flat. Try to minimize the amount of time a patient is on a backboard. So this is why we check CSM before and after. Anytime we C-spine somebody, it's important to make sure that they're still getting good circulation, good perfusion to all extremities. Cervical collar helps maintain spinal motion restriction. The best time to apply the cervical collar depends on the patient's injuries. Once the cervical collar is on, do not remove it unless it causes a problem with maintaining the airway. Remember, once the patient's in a C-collar, once the patient's a C-spine, you're not touching them. You're not taking any of that stuff off until you get to the hospital. Assessing for signs and symptoms of a head or spine injury. Ask about the chief complaint. Confused or slurred speech, repetitive questioning, or amnesia in responsive patients is a good indication of a head injury. So the patient continues to ask you, what happened? Where am I? Where are we going? That's going to be repetitive questioning. And you should have a high index of suspicion of a brain injury in that. In the setting of trauma, assume your patient has a head injury until your assessment proves otherwise. Patient is found unresponsive. Emergency responders, family members, or bystanders may have helpful information. Unresponsive trauma patients should be assumed to have a spinal injury. So anytime you have somebody that's altered, a GCS of less than a perfect 15, and that suffered a traumatic event, you're C-spining a patient because they can't tell you if they're actually having pain or they have or they don't have feeling in their legs or their arms. So you're C-spining everyone who's altered, that suffered a traumatic injury, or that you think may have suffered a traumatic injury. Patients with decreased level of responsiveness should be considered to have a spinal injury based on their chief complaint. Airway, breathing, circulation considerations. Use a jaw thrust maneuver to open the airway. If the jaw thrust maneuver is ineffective, use the head tilt chin lift maneuver as a last resort. Vomiting may occur in the patient with a head injury. Irregular breathing may result from increased ICP. Oxygen is always indicated for patients with head and spinal injuries. Pulse oximetry values should be maintained above 90%. So remember what we're shooting for. We're shooting for 94 to 99% at least. So go ahead and throw a non-rebreather on them. Remember those little hooks on the C-collar. That's what they're there for, to hook on your non-rebreather, to hook on your nasal cannula. Hyperventilation should be reserved for specific conditions. A pulse that is too slow in the setting of a head injury can indicate a serious condition. A single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage and even death. Assess for signs and symptoms of shock. Control bleeding. Manner of transport. Patients with impaired airways, open head wounds, or abnormal vital signs may need to be rapidly extricated from a motor vehicle and transported. Providing the patient with a patent airway and supplemental oxygen is paramount. Suction should be readily available. Maintain immobilization of the spine. History taking. Investigate the chief complaint. Find out what happened. Ask bystanders if the patient's altered. Ask family members if they saw anything. And then I'll try and get a sample history as well from bystanders, friends, family, who's ever on scene, and be alert for injury-specific signs and symptoms, as well as pertinent negatives. Using OPQRST may provide some background on isolated extremity injuries. Gather as much sample history as you can while preparing for transport. Instruct the patient to keep still and not to move the head or neck. Physical examinations may be systemic head to toe, full body scan, or systemic assessment that focuses on a certain area or region of the body. So any multi-system trauma or any major trauma, you're going to do a full head to toe assessment on patients. You're going to strip and flip, so cut off all their clothes, put them on a backboard. Everyone gets vital signs. Significant injuries may cause the pulse to be slow and the BP to rise. With neurogenic shock, the blood pressure may drop and the heart rate may increase to compensate. Respirations will become erratic. Use monitoring devices. So use SpO2, use N-Tidal if you guys are able to, if you guys are with a medic. Perform a full body scan using DCAP BTLS and examine the head, chest, abdomen, extremities, and back. Check perfusion, motor function, and sensation in all extremities prior to moving the patient. Remember what DCAP BTLS stands for. Remember what you're looking for. A decreased level of consciousness is the most reliable sign of a head injury. Look for leaking blood or CSF. Assess pupil size and reaction to light. Continue to monitor the pupils. Do not probe open scalp lacerations with your gloved finger. Make note of it and estimate how big it is. So approximately 2 inches long, approximately 3 inches long, and approximately an inch wide. Doesn't have to be exact. Neurologic examination. Perform baseline assessment using the Glasgow Coma Scale or GCS. Always use simple, easily understood terms when reporting the level of consciousness. Record levels of consciousness that fluctuate or deteriorate. So remember, you guys should know this by now. This is something you guys should know, especially if you get a trauma. The hospital's going to ask what their GCS is, and you got to know it off the top of your head. So eye-opening, 4, 3, 2, 1. Best verbal response, 5, 4, 3, 2, 1. And best motor response, 6, 5, 4, 3, 2, 1. So 4, 5, and 6. Score 13 through 15 may indicate mild dysfunction. Score 9 to 12 may indicate moderate dysfunction. Anything 8 or less indicative of severe dysfunction. So anything less than 8, what we say is anything less than 8, we're going to intubate. So you got to watch their airway, protect their airway. So spine examination, inspect for decap BTLS and check the extremities for circulation, motor, or sensory problems. If there is impairment, note the level. Pain or tenderness when you palpate the spinal area is a warning sign. Other signs and symptoms include deformity, numbness, weakness, or tingling in the extremities, and soft tissue injuries. Reassessment. Repeat the primary assessment. Repeat your ABCs. Reassess vital signs in the chief complaint. Is the patient getting better? Is the patient getting worse? Recheck your patient interventions. These injuries can suddenly affect the respiratory, circulatory, and nervous system. So continuously recheck CSM and extremities that you might have splinted. Reassess at least every 5 minutes. So multiple interventions may be necessary in patients with head and spinal injuries. Compare baseline vital signs with repeated vital signs. Changes will often tell you if treatments have been effective. You will notice deterioration in conscious patients' awareness of time, place, and person. Self in that order. You must act quickly to evaluate and treat these patients. If CSF is present, cover the wound with sterile gauze, but do not bandage tightly. Administer high flow oxygen and apply a cervical collar. So communication, documentation. Documentation should include the history you obtained at the scene, your findings during your assessment, treatments you provided, how the patient responded to them. Document vital signs for unstable patients every 5 minutes, every 15 for stable patients. 3 general principles. Establish an adequate airway. Constantly maintain that patent airway. Control bleeding and provide adequate circulation to maintain a cerebral perfusion. Begin CPR if necessary. Follow standard precautions. So always minimum is wearing gloves, your standard precautions. Assess the patient's baseline level of consciousness and continuously monitor. Managing the airway. The most important steps is establish an adequate airway. Perform the jaw thrust maneuver. Once the airway is open, maintain the head and cervical spine in neutral inline position until you have placed a cervical collar and have secured the patient on a backboard. Okay, so remember, you're always holding C-spine. This person's holding C-spine. You're never going to let go, even after you get a collar on. This person's placing the collar on. So remove any foreign body secretions or vomitus. You have suction ready to suction any foreign bodies out. Make sure a suctioning unit is available. Check ventilation. Give supplemental oxygen to any patient with suspected head injuries. Circulation. Begins CPR if the patient is in cardiac arrest. Active blood loss aggravates hypoxia. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. Shock is usually a result of hypovolemia. It indicates the situation is critical. Transport immediately to a trauma center. Cushing's triad. Increased blood pressure, hypertension, decreased heart rate, bradycardia, irregular respiration, Shane-Stokes, or Biot respirations. Perform controlled hyperventilation of your patient via positive pressure ventilations at a rate of 20 breaths per minute. So know your Cushing's triad. Know how to recognize it. Know the 3 signs and symptoms: increased blood pressure, decreased heart rate, and irregular respirations. So always follow standard precautions. Maintain the patient's airway while keeping the spine in the proper position. Assess respirations and give supplemental oxygen. Managing the airway. Perform the jaw thrust maneuver. After you open the airway, consider inserting an OPA or oropharyngeal airway. Have a suctioning unit available. Provide supplemental oxygen. Okay. So this is your jaw thrust maneuver. So he's holding C-spine in place, and he's also just pushing the jaw down. Okay, that way you're not manipulating the neck, manipulating the head in case he has a possible head injury. Mobilization of the cervical spine. Immobilize the head and trunk so that the bone fragments do not cause further damage. Never force the head into a neutral inline position. Immobilize the patient in his or her current position. So if a patient can't put their head in a normal or inline position, or if their patient's head is tilted to the right or left and they can't move it, you're going to have to do what's called modified C-spine. Put them on the board and put a pillow and make sure their head doesn't move around. That's modified C-spine. Cervical collars provide preliminary partial support. Should be applied to every patient who has a possible spinal injury. To be effective, a rigid cervical collar must be the correct size. So on some adults or some older people, you're going to have to put a pediatric collar on them because this adult collar is going to be too big. So always measure your cervical collars. Make sure they're the right size. And then here we have another person holding C-spine. So they look like they're sitting down in a chair. So they're probably going to throw a KED on this patient. Cervical collars should rest on the shoulder girdle and provide firm support under both sides of the mandible without obstructing the airway or ventilation. Once the patient's head and neck have been manually stabilized, assess the pulse, motor function, sensation in all extremities. Then assess the cervical spinal area and neck. Preparation for transport. Supine patients. Secure to a long backboard or vacuum mattress. Another procedure to move a patient from the ground to a backboard is a 4-person log roll. You may also slide the patient into a backboard or vacuum mattress. So always try and have at least 4 people when you're doing a log roll, especially larger patients. Makes things a lot easier. And you don't forget to assess the back as well. Palpate along the spinal cord. Vacuum mattress. An alternative to the long backboard is a vacuum mattress. Molds to the specific contours of the patient's body. Excellent for the elderly or a patient with abnormal curvature of the spine. Can be used on a supine sitting or standing patient. Sitting patients. Use a short backboard or KED to restrict movement of the cervical and thoracic spine. Then secure the short board to the long board. Exceptions include situations in which you or the patient is in danger and there's need for immediate movement, or you need immediate access to other patients. So say if someone's trapped in a car and the only way you get through them is through one door and there's a person or people in front of you and that you have to remove quickly. The patient's injuries justify urgent removal. Standing patients. Mobilize the patient to a long backboard before proceeding with assessment. Establish manual inline stabilization and apply a cervical collar. Position the board upright directly behind the patient. Carefully lower the patient as a unit under the direction of the EMT at the head. Spinal mobilization devices. Assume the presence of a spinal injury in all patients who have sustained head injuries. Use manual inline stabilization or cervical collar and long backboard. Short backboards, vest type device and rigid shortboard. Designed to immobilize and restrict movement of the head, neck, and torso. Used to immobilize non-critical patients found in sitting position. So remember, what's the mnemonic for using the KED? How do you guys use it? There's 2 mnemonics you guys can use. My baby looks hot tonight, or money buys lots of hot toys. So pretty much the simplest way to remember is start at the middle and just go all the way down. Middle, bottom, legs, back up to the head, and then the top. And then you can readjust your straps after that. So if someone's sitting down and you want to immobilize them, you could put the KED right behind them. So long backboards provide full body spinal mobilization, motion restriction to the head, neck, and torso, pelvis, and extremities, used to immobilize patients found in any position. So helmet removal. Helmet that fits well prevents the patient's head from moving and should be left on provided there are no impending airway or breathing problems. It does not interfere with assessment and treatment of airway or ventilation problems. You can properly immobilize the spine. Remove a helmet if it's a full face helmet and you don't have access to the patient. Makes assessing or managing airway problems difficult. So if you're unable to check out a patient or look at their airway or monitor their respiration, so you're going to have to remove it. It prevents you from properly mobilizing the spine. It allows excessive head movement, so there's a lot of room in that helmet for your head to move around. The patient is in cardiac arrest. That's kind of a given. Patient's in cardiac arrest, you're going to take everything off anyways, because you have to bag that patient. So preferred method, removing a helmet should always be at least a 2-person job. You should first consult with medical control about your decision to remove a helmet. Alternate method, the advantage is that it allows a helmet to be removed with the application of less force, therefore reducing the likelihood of motion occurring in the neck. The disadvantage of that is it is slightly more time consuming. Remove the chin strap, remove the face mask, pop the jaw pads out of place, place your fingers inside the helmet. Hold the jaw with one hand, the occiput, or the backside of the head with the other. Insert padding behind the occiput. The person at the side of the patient's chest is responsible for making sure the head and neck do not move during the removal of the helmet. Remember that children may require additional padding to maintain the inline neutral position. Remember just the way that their body is. Their head's going to be a little bit bigger, so it's going to kind of come forward a little bit, and it's not going to be in line. So you're going to have to pad underneath the shoulders. Okay, so the brain, a part of the central nervous system, is divided into the cerebrum, cerebellum, and brainstem. Cerebrum, brainstem, and spinal cord, cerebellum, cerebrum, and spinal cord, cerebrum, and cerebral cortex. So what are the 3 parts of the brain? So A, the brain and spinal cord comprise the central nervous system. The brain is divided into 3 major regions: the cerebrum, the largest portion, the cerebellum, and the brainstem. Each region of the brain carries out specific functions. As you're assessing a 24-year-old man with a large laceration on the top of his head, you should recall that So B, although the scalp is highly vascular and tends to bleed heavily when injured, scalp injuries are rarely the sole cause of hypovolemic shock in adults. However, they can contribute to hypovolemia caused by injuries elsewhere in the body. Scalp lacerations, whether deep or superficial, should prompt you to look for more serious underlying injuries, such as a skull fracture. If the injury involves an avulsion, the avulsed flap of skin should be carefully replaced to its original position, not cut away. A patient who experiences an immediate loss of consciousness followed by a lucid interval has a A, epidural hematomas are caused by injury to an artery, usually the middle meningeal artery that lies in between the skull and brain. Patients with an epidural hematoma typically experience an immediate loss of consciousness, followed by a brief period of consciousness lucid interval as intracranial pressure increases. Subdural hematomas are the result of injury to a vein. Therefore, they tend to bleed slowly and usually cause a progressive decline in level of consciousness. Concussions and contusions may cause a loss of consciousness, but it is typically brief. A 44-year-old man was struck in the back of his head and was probably unconscious for approximately 30 seconds. He complains of a severe headache and seeing stars, and states that he regained his memory shortly before your arrival. His presentation is most consistent with a what? So B, concussion occurs when the brain is jarred around inside the skull. It may result in a brief loss of consciousness and occasionally amnesia. Seeing stars is a common finding following trauma to the back of the head, occiput, as this region is primarily responsible for vision. A concussion, the least severe of all closed head injuries, typically does not result in physical damage to the brain. Compared to a concussion and contusion, subdural hematoma and or cerebral hemorrhage are usually associated with a more prolonged loss of consciousness. A young male was involved in a motor vehicle accident and experienced a closed head injury. He has no memory of the events leading up to the accident, but remembers that he was going to a birthday party. What is the correct term to use when documenting his memory loss? So remember, amnesia is memory loss. What kind of amnesia did he suffer? So C, the term amnesia means lost memory. It is common in patients who have experienced a cerebral concussion. Amnesia of events leading up to an injury is called retrograde amnesia. Anterograde amnesia, also called post-traumatic amnesia, is an inability to remember events that occurred or will occur after the injury. So after the patient got injured, they are unable to tell you what happened. So that's anterograde amnesia. So distraction injury to the cervical spinal injury or cervical spine would most likely occur following a So D, excessive traction on the neck, such as what occurs during hanging type mechanism, can cause a distraction injury of the cervical spine. Distraction injuries can cause separation of the vertebrae and stretching or tearing of the spinal cord. During immobilization of a patient with this possible spinal injury, manual stabilization of the head must be maintained until when do you guys let go of C-spine? When's the only time you guys let go of C-spine? So B, manual stabilization of the patient's head must be maintained until he or she is fully secured to the long backboard. This includes the application of an extrication collar, straps, and lateral immobilization head blocks. Pulse, motor, and sensory function must be checked before and after the mobilization process. Do not assess range of motion in a patient with a possible spinal injury. This involves moving the patient's neck and may cause further injury. So remember, you never let go of C-spine until the patient's fully mobilized, strapped into the board. Check CSM before and after. That's a critical fail if you guys miss CSM before and after. Your patient is a 21-year-old male who has massive face and head trauma after being assaulted. He is lying supine, is semi-conscious, and has blood in his mouth. You should So C, blood or other secretions in the mouth place and airway in immediate jeopardy and must be removed before they are aspirated. At the same time, you must protect the patient's spine due to mechanism injury. Therefore, you should manually stabilize the patient's head, log roll him onto his side, allow drainage of blood from his mouth, and suction his mouth for up to 15 seconds. After ensuring that his airway is clear, assess his breathing and give high flow oxygen or assist his ventilations. Nasal airways should not be used in patients with severe facial or head trauma. So remember, MPAs are not going to be used with severe facial or head trauma. It might increase bleeding inside the brain, might poke a clot loose. So always beware of putting MPAs in head traumas. Man is found slumped over the steering wheel, unconscious and making snoring sounds after an automobile accident. His head is turned to the side and his neck is flexed. You should So D, the patient's snoring sounds indicate an airway problem which must be corrected or he may die. Manually stabilize his head, carefully move it to a neutral inline position, and reassess his breathing. Do not rotate or hyperextend the neck of a patient with a possible spinal injury. The results could be disastrous. You should not remove an injured football player's helmet if So D, in general, you should leave a helmet on if it fits snugly and does not allow movement of the head within the helmet. Patient's airway is patent and no airway problems are anticipated and the patient is breathing without difficulty. If you could remove the face guard, often the case with football helmets, and there are no airway problems, do so, but leave the helmet on. If the helmet is loose, the airway is in an airway compromised, or the patient has difficulty breathing or is in cardiac arrest, the helmet must be removed.